Welcome to this explainer on Andy's Orthohantavirus. Today, we're unpacking the clinical and microbiological profile of what is, quite frankly, a massive virological outlier. Tailored specifically for medical microbiologists and clinical virologists here in the Netherlands, we're going to cover its taxonomy, its clinical presentation, and how our Dutch RIVM guidelines stack up against international standards.
Right, let's jump straight in.
So let's start with a really central question. Why exactly does this specific pathogen just completely break the golden rules of its viral family? Well, the answer lies in its unprecedented transmission dynamics and ecological plasticity, and as you'll see, that makes it an absolutely critical threat to understand in our highly interconnected world.
Okay, looking briefly at the taxonomy, Andy's Orthohantavirus sits within the order of Bunyavirales, but unlike most members of this order, which are usually arthropod-borne, it actually belongs to the family Hantaviridae. That means it relies entirely on vertebrate hosts, specifically rodents. Zooming in a bit further, it's categorized under the Orthohantavirus genus, and its official species designation is Orthohantavirus ondensans.
Morphologically speaking, we're looking at an enveloped, roughly spherical virion, measuring somewhere between 80 to 120 nanometers in diameter. Tucked inside that envelope, it's a negative-sense single-stranded RNA virus with a really unique tripartite or three-part genome. It's kind of like a genetic puzzle. The large segment encodes the viral polymerase, the medium dictates the envelope glycoproteins, and the small segment encodes the nucleocapsid. Understanding this three-part structure is totally vital for us when tracking viral evolution and reassortment.
Now, here's the real game changer. This is where it completely breaks the rules. While your standard hantaviruses, like the ones causing hemorrhagic fever with renal syndrome here in Europe, are strictly zoonotic, Andy's Orthohantavirus is the literal only member of its family proven to spread directly from person to person. Sustained generational transmission isn't just some hypothetical scenario here. It's a documented reality.
Out in the wild, its natural reservoir is the long-tailed pygmy rice rat, which is endemic to the forests of Argentina and Chile. Typically, humans get infected by inhaling aerosolized rodent saliva, urine, or feces. And the wild part? The rodents themselves remain completely asymptomatic. They just act like persistent mobile biofactories that are continuously shedding the virus into the environment.
But what happens when this very local threat suddenly collides with global travel? Well, the 2026 outbreak aboard the MV Hondius cruise ship proved that geographical boundaries basically no longer apply. This cluster out in the Atlantic Ocean starkly demonstrated that enclosed spaces and poor ventilation can rapidly accelerate person-to-person spread, turning what should be a localized South American pathogen into a full-blown international crisis.
Moving on to Section 1, the clinical picture, specifically Hantavirus Pulmonary Syndrome. So Andy's Orthohantavirus is the primary driver of Hantavirus Pulmonary Syndrome, or HPS, which is a remarkably severe respiratory disease. A really landmark case report from an ICU in Temuco, Chile, perfectly outlines this rapid clinical deterioration. In a cohort of 16 adult patients, mostly agricultural workers, the illness started with a deceptively simple flu-like phase. But then, within just 1 to 7 days, these patients completely crashed into sudden respiratory insufficiency, severe hypoxemia, and hemodynamic instability as fluid literally flooded their lungs.
For us, especially if you're a Dutch clinical microbiologist evaluating a returning traveler, the diagnostic profile here is highly specific. You want to look for hallmark laboratory abnormalities. We're talking severe hemoconcentration, profound thrombocytopenia, leukocytosis, and an altered partial thromboplastin time. Hemorrhage and renal involvement were also super frequent complications in that Temuco cohort. To put that severity into perspective, these clinical indicators culminated in a staggering mortality rate within that cohort of 43.8%. That is almost half. It really underscores the extreme lethality of the virus once that cardiopulmonary phase kicks in, and it's exactly why rapid accurate diagnosis is quite literally the difference between life and death. Now, while viral culture on Vero E6 cell lines is technically possible, the lack of distinct cytopathic effects makes it incredibly slow and honestly just very difficult to observe. So when it comes to molecular detection, early timing is absolutely everything. During the acute phase, the laboratory pathway relies entirely on RT-PCR and nucleic acid sequencing. Later on, during the convalescent phase, the diagnosis is confirmed serologically using ELISA testing for hantavirus-specific IgM and IgG antibodies.
Which brings us to Section 2,
clinical management, and navigating both Dutch and international guidelines.
So, once we've detected it, how do we actually treat it? Well, looking at both our Dutch RIVM guidelines and international WHO or CDC protocols, we hit a stark, unified reality. There is zero approved specific antiviral therapy for Andes orthohantavirus. None. While some guidelines for other hantaviruses might suggest restrictive antiviral use, the Dutch protocols explicitly advise against using any antiviral agents, and yes, that includes ribavirin.
And because we literally don't have an antiviral framework here, a lot of our standard microbiological questions just don't apply. There are no specific pediatric antiviral dosages to calculate, nor is there any clinical role for analyzing intrinsic or acquired resistance mechanisms. Antiviral susceptibility testing is essentially a non-factor for this pathogen.
Instead, the entire cornerstone of treatment, survival really, hinges on rigorous supportive care in the ICU. The primary medical battle is managing the patient's oxygenation while strictly avoiding iatrogenic fluid overload, particularly during their oliguric phase when renal function crashes. Meticulous hemodynamic monitoring is the absolute cornerstone of treatment here.
Because of all this, infection prevention and control, or IPC, becomes our absolute strongest defense. In the community, this just means avoiding rodents. But in a Dutch healthcare setting, because this specific virus can spread from person to person, standard hygiene is nowhere near enough. We have to implement stringent transmission-based precautions, strict patient isolation, and comprehensive contact tracing.
Thankfully, global organizations like the International Society for Hantaviruses are monitoring these outbreaks super closely. Their ongoing work in genomic characterization and epidemiological tracking is completely critical for public health, especially as we keep observing these spillover events pushing into entirely new geographical regions.
So I'll leave you with this final thought.